Good afternoon and welcome, dear participants. My name is Dr. Khalid Gashwa. I am a continuous medical education team co-lead in Yetenaweg. Today we'll be having our bi-weekly continuous medical education webinar. We have Dr. EYOB BEYENE with us, who is a consultant internist and infectious disease subspecialist. It's a great honor to have him here with us. Before we pass on to the webinar, I'll be giving a brief introduction about Yetenaweg, what we do. Hopefully you'll find it informative. So Yetenaweg is a group of, a network of volunteers, which is a registered nonprofit run entirely by volunteer members. To date, we have 135 active members across 5 different countries, and we're still recruiting numerous volunteers. So our main areas of we do through discussion and timely health articles, which is prepared by different experts on various topics. We also involve in community engagement like blood drive activities, equity projects, fundraising campaigns, and so forth. We have a mentorship and skill sharing programs, and finally medical education. So this CME session is one part of this medical education project. So as you can see here, we engage in various community outreach programs, including blood drive and so forth. So Yetena also prepares article competitions, which is one way of engaging medical students, medical professionals to actively participate in the service to the community. So our continuous medical educations are freely accessible. There is no payment, it's fully free. And we partner with Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, and Ethiopian Dermatology Health Professionals. We invite renowned experts, both nationally and internationally. So our participants get to experience updated information on each topic. So far we have done 30 continuous medical education webinars, and in 2023 alone, 40 webinars were outlined focusing on non-communicable disease, current issues, mental health, and SRHR topics. So where can you access our previous CME sessions? You can access them on the Yetenaweg YouTube channel, which will share the link on the chat section. So you can go through our YouTube channel to find previously done CME sessions. So where to get updates about our upcoming continuous medical education sessions? You can find them on Yetenaweg's Telegram channel for healthcare professionals. We'll be sharing the link in the chat section. So we'll be posting continuous updates on upcoming CMEs. You can also follow us on social media to find our latest information. So one of our major programs include the Yetenaweg Roha Research Fellowship. So it's done in collaboration with Roha Health, and it focuses on research and QI. So it will be made public in our social media platforms, building the knowledge gap, networking, and encouraging local funders. So in this webinar, for based experience, dear participants, send your questions on the Q&A or the chat section. At the end of the webinar, you will have the chance to ask the speaker if you have a question and if you raise your hand. To get the certificates, attendants must fulfill the following criteria. So the first one is attend the whole session, and second one, fill the Google form that we will share at the end of the webinar, and there will be 4 quiz questions. So in order to be certified, you need to get 50% or more on the post-webinar quiz. So you'll get your results right away. The certificate might take 1 to 2 weeks, but it will be delivered through your emails once the preparation is done. So thank you very much. Now I'll be introducing our guest speaker. So Dr. EYOB BEYENE is today's guest speaker. He is the consultant internist and infectious disease subspecialist, currently working at Addis Ababa University College of Health Sciences. He's currently the head of infectious disease unit at the Department of Internal Medicine. He has received his Doctor of Medicine from Jimma University School of Medicine. He served as a general practitioner and did his specialty and subspecialty training at Addis Ababa University College of Health Sciences. So, as you all know, the challenge of communicable diseases has still followed us to the 21st century. There is a rising challenge of multi-drug resistant pathogens, as well as multiple infectious agents causing epidemics and pandemics, which calls for the leading role and expertise by infectious disease specialists, such as our guest speaker today, Dr. EYOB. We'd like to thank Dr. EYOB so much for taking his time to be with us and share his expertise on the topic. I now give the floor to Dr. EYOB.
So thank you, Dr. Caleb, for the kind introduction. So today we have an important topic, carbapenem resistance and carbapenem sparing strategies. So this is my outline of presentation. I will try to see mechanisms of antimicrobial resistance, especially beta-lactam resistance, and we'll focus on Carbapenem-resistant Entero-bacterales. Previously, it was used to be called Entero-bacterales, and we will focus on also difficult to treat Pseudomonas aeruginosa and Carbapenem-resistant Acinetobacter baumannii, or CRAB. So I may exchangeably use CRE and CRAB when I refer to these pathogens. And finally, we will discuss about carbapenem sparing strategies, carbapenem sparing strategies. As you all know, most of the ICU admissions, ICU days are because of gram-negative pathogens, gram-negative pathogens. So the gram-positive pathogens contribution is decreasing, and currently the main contribution culprits for the morbidity and the mortality are the gram-negatives: E. coli, Klebsiella pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa, as you can see from this 2007 data, which was a one-day point prevalence study from more than 13,000 patients. 70% of the infected patients have culture results which are gram-negative organisms. So most of the gram-negative pathogens, mostly gram-negative pathogens, are culprits for severe diseases and diseases, and their contribution is increasing throughout the years. So as you can see, these are the list of the bacteria, but although gram-positive pathogens like Staph aureus, yeasts like Candida have a contribution, gram-negative pathogens dominate and lead causing morbidity and mortality in ICUs and other setups, other inpatients and outpatient setups. So resistant gram-negative organisms, recently there is dramatic increase, and it's going to increase with time. This is 2030 prediction, so 2050 prediction. That means in less than 30 years from now, in 20-something years, the world is going to see diseases. You might have seen this slide repeatedly. Diseases related to antimicrobial resistance. 10 million diseases yearly And as you can see, most of the days are in Africa and Asia, developing countries. This is not comparable to even COVID, and also it will surpass the diseases from cardiovascular diseases, cancer diseases, and I think this prediction is even coming earlier. We are seeing currently the effects of resistant gram-negative pathogens. This is the data from Black Lion Hospital, 1 year data. I took it from the antibiogram of the hospital from April to March 2023. And as you can see, the meropenem resistance, there is resistance to almost all pathogens, but resistance to meropenem, carbapenem, is reaching as high as 50%, 50%, and ceftriaxone 88%. So E. coli resistance to meropenem is 25%. This is Klebsiella, this is for E. coli. And this is a very huge number, a very huge number. So it's not officially released, but we use it for the antibiogram. We have prepared it, it's prepared for antibiogram of the year of the Black Lion Hospital. So as you can see from 134 cases, 57 cases were resistant to meropenem. 50% resistance to carbapenem is very dangerous to the infectious disease treatment strategies. So how do we get here? How do we get into this mess? So initially, gram-negative pathogens were susceptible to antibiotics, even to the ampicillin, and the different beta-lactams starts to be produced. And when you start to use different antibiotics and overuse, abuse, a lot of beta-lactamases start to occur in the world. So the beta-lactamases, we classify them into 4 groups. In general, the 3 groups are serine beta-lactamases, and 1 group is metallo-beta-lactamase, which usually uses zinc. This is the serine is the substance they hydrolyze. So from the serine group C, A, D, where we are serine groups, and metallo-beta-lactamases are grouped as group B based on the Amber classification. And this is how we classify them. But from this group, like we take important beta-lactams, like metallo-beta-lactamases from the group B. They are very important, and we'll talk about them in detail. And from the serine group, they are the AMPC, the OXA48, and the KPC, Carbapenem-resistant Klebsiella pneumoniae, which is carbapenem is producing Klebsiella pneumoniae. These are very important. This is how we classify beta-lactamases. So this is the list of the beta-lactamases. We will not go in detail into this beta-lactamases list. So there are a wide variety of mechanisms and bacteria used for antimicrobial resistance. One is like degradation, like beta-lactamase production. The other is they change their pouring channels, and also they have efflux mechanisms. They pump out the antibiotic. Notorious pathogens like Pseudomonas, they will do that. And also target changes are also important mechanisms for antibiotic development resistance. That means efflux pumps, permeability changes, target site mutations, and also beta-lactamases. The problematic beta-lactamases, the AMPC, the ACDL, the metallo-beta-lactamase, the KPC, these are very important beta-lactamases, like ACBL, everybody says ACBL, and what is ACBL we have to know, and how to treat ACBLs, even though this is not the topic of our today's discussion. We have to know about this beta-lactamases. Our today's topic is carbapenem-resistant beta-lactams. You have seen the data. It was 30%, 25%. Now we are seeing even a resistance rate as high as 50%. And we see this also in other setups, in private setups, other hospitals who do culture properly. They are seeing these carbapenem-resistant pathogens. That's why I'm talking about this topic today. So we have seen them a lot. So the mechanism of resistance, we have discussed that, impaired permeability, absence of porine channels and deflex mechanisms, changing targets, biofilm formations, especially in the catheters, lines, central lines, prosthetic materials, there will be biofilm formation, and the bacteria will be difficult to eradicate unless the prosthesis or the catheter is removed. In general, bacteria like Pseudomonas also, they use all the available mechanisms of resistance. That's why we use multiple drugs to treat them. So OPRD mutation, that means the porine channel mutation, is also an important mechanism in Pseudomonas aeruginosa resistance. So in general, this is the concept map for carbapenem resistance. So we can classify them into two. Carbapenem is producing, and also non-carbapenem is producing bacteria. The carbapenem producing, like the KPC, when you see KPC, it's absolutely carbapenem resistant, because Klebsiella pneumonia, which is carbapenem is producing. So metallo-beta-lactamases, they are carbapenem resistant. The class from the class D, the OXA48 is producing carbapenem. So this is high level resistance, and the other group is beta-lactamases, efflux mechanisms, increased permeability. They use all this to cause resistance, but we call this low-level resistance. So carbapenem production is high-level resistance, and those who use other ways, they have low-level resistance. So recently, the IDSA has published an update on management of resistance gram-negative infections. It's very recent. It's released in June 7, 2023. June 7, 2023. So I will take also some pointers from this IDSA 2020 guideline. So the first topic that we see is carbapenem producing Entero-bacterales. So Entero-bacterales resistance is defined as resistance to at least one carbapenemase. And we can use the MIC for meropenem greater than 4, and for iftapenem greater than 2. For meropenem, doripenem, imipenem, you can use MIC of greater than 4 milligram per deciliter. In general, Entero-bacterales resistance to one carbapenem are named carbapenem-resistant Entero-bacterales. So the KPC is most common, and New Delhi metallo-beta-lactamase second most common. Klebsiella pneumoniae producing carbapenemases, and also the New Delhi metallo-beta-lactamases, the class B from the Amber classification, from predominates. And also these organisms, they have also wide range of ACBL enzymes. So identifying the presence of carbapenemase and which type is also important for treatment. But in our country, what we are doing is just a drug sensitivity test for carbapenemase, but identifying which type of carbapenemase the organism processes is very important for drug selection and subsequent plan. So the IDSA, the 2023 guideline asks different questions, and it tries to answer these questions. So the first question that was asked was, what are the preferred antibiotics for treatment of uncomplicated cystitis caused by Carbapenem-resistant Enterobacterialis? So uncomplicated cystitis, that means lower urinary tract infection, should be treated by nitrofurantoin, cotrimoxazole, ciprofloxacin, or levofloxacin. For uncomplicated caused by this carbapenem is producing Enterobacterialis. A single dose of fosfomycin also can be tried for E. coli. And the colistin, ceftazidimabibactam, meropenem, vabrobactam, imipenem, celastatin, develobactam, cefedricol, these are all alternative treatment for uncomplicated cystitis caused by CRE. So we can use only for uncomplicated cystitis. We can try nitrofurantoin, trimethoprim, sulfamethocin, cipro for lower urinary tract infections, and the colistins and newer beta-lactam is like ceftazidimabibactam, meropenem, vabrobactam, imipenem, celastatin, relebactam, cefedricol. They are all alternatives. So we will. I know these antibiotics might be new for some of us, but throughout this presentation, I will talk about them and I will repeat their names. So we have to get familiarized with these antibiotics, and also we should have them. We have 50% of gram-negative Klebsiella pneumoniae unresponsive to carbapenems in one of the biggest hospitals in the country. So we should know about them and we should know how to treat them. So the other question that's asked is, what are the preferred antibiotics for treatment of pyelonephritis and complicated UTI caused by CRE? So you can use the above antibiotics, but the newer beta-lactam is also preferred treatments. They are not alternative in case of pyelonephritis and complicated UTI. Aminoglycosides are alternative treatment options if the renal function test is normal or the kidney function is deemed to be acceptable. Aminoglycosides can be used, but they are not the preferred alternatives. They are the alternatives. So what are also the preferred antibiotics for the treatment of infection outside of the urinary tract caused by CRE or Carbapenem-resistant Enterobacterialis? So these are the preferred alternatives are the newer beta-lactam combinations. Meropenem, vabrobactam, ceftazidimabibactam, imipenem, celastatin, relebactam, and cefedricol. So what are also the preferred treatment antibiotics for treatment of infections outside of the urinary tract caused by CRE if New Delhi beta-lactamase is present? If this NDM is present, ceftazidimabibactam in combination with azithromycin can be used. This the New Delhi beta-lactamase is notorious beta-lactamase, and it will not respond even to the newer beta-lactamase combinations. So the preferred one is ceftazidimabibactam with azithromycin. So we usually see sensitivity to azithromycin when you do cultural sensitivity for the New Delhi beta-lactamase, but we will not use azithromycin alone. So ceftazidimabibactam in combination with azithromycin is an option, and also equal to the cefedricol monotherapy can be used. These are the two are the preferred options for New Delhi beta-lactamase producing infection. So this is initially discovered in New Delhi, England, New Delhi, India, but currently we don't know where we are about the New Delhi metallo-beta-lactamases. So the two options are equally alternative, but there is no much data to prefer one over the other. So tigacycline and ervacycline can be used if the infection is not involving the bloodstream or urinary tract, and the activity is independent of the presence of carbapenem-resistant. But you have to remember that ceftazidime-avibactam with azithromycin and cefedricol alone is the preferred option for NDM metallo-beta-lactamase producing pathogens. So what is the role of polymyxins for the treatment of infections caused by CRA, Carbapenem-resistant Enterobacteriales? According to this guideline, the 2023 panel of experts release, polymyxin B or colistin use is not suggested as a treatment option caused by CRA. Colistin can be considered as an alternative agent for uncomplicated cystitis. So the observational data has shown that mortality, nephrotoxicity related to polymyxin B and colistin are present, and polymyxin B and colistin are not the preferred options based on this guideline. But when you come to our country, we don't have all the alternatives. So if you have polymyxin B and colistin, we might need still to use them. Polymyxin B is less toxic than colistin, but polymyxin B cannot be used for cystitis and pyelonephritis. It will not typically reach to the urinary system. So if you have cystitis, pyelonephritis, you have to use colistin, which is more toxic than polymyxin B. The guideline recommends against avibactam, meropenem-avibactam, imipenem-cilastatin-rilibactam, and the alternative is cefedricol. Cefedricol is made alternative because it's very important for metallo-beta-lactamase producing bacteria treatment, because we have to, that's why they put it as an alternative, because we have to preserve it for the treatment of this New Delhi metallo-beta-lactamase producing bacteria. So that's why cefedricol is preserved in treatment of carbapenem testing in case where carbapenem testing is not available or KPC is present. So if there is New Delhi metallo-beta-lactamase production, ceftazidime-avibactam with azithromycin is preferred option. Cefedricol alone is also an equally preferred alternative. And tigacycline and ervacycline, if there is no bloodstream infection or UTI, can be used. So OXA48 producing pathogen, still ceftazidime-avibactam should be used, and cefedricol is an alternative. So CRP pyelonephritis, if only ertapenem resistance is present, we can still try the other carbapenems, like extended infusion of meropenem, giving it over 4 hours infusion or giving it as a continuous infusion with higher doses like 2 gram PID or 6 gram over 24 hours can be tried. If there is other carbapenem resistance, especially meropenem resistance for pyelonephritis, we have to use ceftazidime-avibactam and other medications. But once daily aminoglycoside is also an option if renal function derangement is acceptable in the individual case. So the other notorious pathogen is Acinetobacter baumannii. If it is present in the ICUs, it is very difficult to eradicate. The setup has to be good for infection prevention, and also every materials, it can stay in dry surfaces for a long time. So treatment of Acinetobacter baumannii, Carbapenem-resistant Acinetobacter baumannii, I might call it CRAB to shorten it. So one thing, if there is CRAB, it is very difficult to differentiate between true colonizer or true pathogen. If it's isolated from blood culture, that's a relief. That means it is the pathogen. But if it's isolated from sputum and other sites, it's very difficult to differentiate from colonization and true pathogen. Usually you have to have this in mind, and we have to use other clues like increased excretion, increased respiratory demand has to be put also in mind. So the crab, they have a lot of resistance. Metallo-beta-lactamase production is also there is saying carbapenem-resistant AMC, and also modifying the target sites, and also their treatment is a little bit different than the CRAs. The crab, carbapenem-resistant Acinetobacter baumannii, treatment is a little bit different. The new beta-lactamase combinations will not work for this Acinetobacter crab infection, carbapenem-resistant Acinetobacter baumannii infection. I'm trying to avoid the abbreviation because some of us might be new to these abbreviations, but I might use them like crab a little bit often. So what are the preferred options? High dose ampicillin sulfactam is the preferred agent for its treatment. High dose ampicillin sulfactam, it means 9 grams of sulfactam should be given in 24 hours. So sulfactam acts as not a beta-lactam, as a treatment for crab, carbapenem-resistant as Acinetobacter baumannii. So alternatives are the minocyclines, polymyxin B, colistin, and also ceftriaxone are the alternatives. So combination therapy is suggested for treatment of moderate to severe infections. I was discussing about mild infections. In severe infection, we usually combine them. Colistin with ampicillin sulfactam with polymyxin B should be combined. We have to avoid colistin as much as possible. If the individual doesn't have cystitis or anaphylactic infection, we have to use polymyxin B. And if colistin is toxic, and if there is an alternative, we have over sulfactam content has to be 9 grams over 24 hours, has to be used. And this novel beta-lactamase combinations will not work for this infection. So the doses and the therapies are mentioned on this table: polymyxin B, colistin, ergocycline, ampicillin sulfactam, ceftriaxone. But we have to remember that 9 gram ampicillin sulfactam is a good alternative. That means 27 grams over 24 hours. It contains 9 grams of ampicillin sulfactam. If we give 27 grams IV over 24 hours over continuous infusion, we can get sulfactam dose of 9 grams. And the other alternatives are polymyxin B and colistin. And ceftriaxone also can be used. But the new beta-lactamase combinations don't work for crab. Another newer drug, sulbactam durlobactam, is also coming to the picture. I didn't include it on this PowerPoint, but two beta-lactamase inhibitors are combined, and this antibiotic is being tried for crab, sulbactam durlobactam. It will be very good if you refer about it. It's very interesting combination. Sulbactam durlobactam is also being tried for Acinetobacter baumannii, carbapenem-resistant Acinetobacter baumannii infection. So the other pathogen is Pseudomonas aeruginosa. Difficult to treat Pseudomonas aeruginosa. So what is difficult to treat Pseudomonas aeruginosa? Difficult to treat Pseudomonas aeruginosa is Pseudomonas aeruginosa which is resistant to all of the antibiotics: piperazine, tazobactam, ceftazidime, cefepime, azithromycin, meropenem and imipenem and fluoroquinolones. If it's resistant to all of these, we say difficult to treat Pseudomonas aeruginosa infection. So am I going fast? Am I audible? Dr. Karim?
You're audible, doctor, and you're going in a very good pace.
Okay, thank you.
It's audible.
So what are the treatment options for difficult to treat Pseudomonas aeruginosa? So carbapenems are also out of option if it is difficult to treat Pseudomonas aeruginosa. So for serious infections, we use beta-lactam. Beta-lactam is the newer beta-lactam is combinations. Ceftazidime-avibactam, clozentazobactam, imipenem, celastatin-relebactam. Although ceftazidime-avibactam is usually preferred, but the ceftolozentazobactam is also as good as ceftazidime-avibactam. And the alternatives is for severe infections is cefidericol. Cefidericol is being reserved for New Delhi. This New Delhi beta-lactam is producing bacteria. So for pyelonephritis and complicated UTI, you can use the cefidericol, ceftolozentazobactam, the same alternatives, but we can also use daily aminoglycoside if kidney function deterioration is acceptable. So cystitis, you can use this beta-lactam is combination. Single dose aminoglycoside also is a very good alternative. It can be also used as carbapenem sparing strategy, single dose aminoglycoside. We shouldn't use meropenem if there is lower urinary tract infection, symptomatic lower urinary tract infection, which is sensitive to meropenem. We have to try them with other antibiotics. We have to use other antibiotics, nitrofurantoin, polymyxin, and single dose aminoglycoside should be used, and meropenem should be reserved. One of the carbapenem sparing strategies in lower urinary tract cystitis. If someone has symptomatic UTI, asymptomatic UTI, you know that it shouldn't be treated unless the patient is pregnant or the patient is going to undergo some invasive urologic procedures. But for symptomatic cystitis, lower urinary tract infection, we can use single dose aminoglycoside if meropenem resistant is there. So this is not about difficult to treat Pseudomonas aeruginosa, but it came into the picture because aminoglycosides are mentioned. So if it is difficult to treat Pseudomonas, a single dose aminoglycoside can be tried. And the alternative is colistin. Colistin is an alternative because it is toxic. It is the side effects are debilitating. So the other question is, what are the preferred antibiotics for treatment of infection caused by MDR Pseudomonas aeruginosa? So traditional non-carbapenem beta-lactam agents are susceptible to traditional, when Pseudomonas aeruginosa tests are susceptible to the traditional non-carbapenem beta-lactam agents, they are preferred over carbapenem therapy. For infections caused by Pseudomonas aeruginosa associated, not susceptible to any carbapenem agent, but susceptible to traditional beta-lactams, a traditional agent at high dose with extended infusion therapy is suggested. But we have to be cautious because Pseudomonas aeruginosa trains itself a lot, and it can develop. You can pick resistances even after 2 days of treatment. So susceptibility tests should be done serially when you use this traditional beta-lactam agents. That means the piperazine-tazobactam and the other traditional beta-lactam agents which are used with Pseudomonas should be used if they are susceptible. For patients with moderate to severe disease or poor source control, use of a novel beta-lactam agent that tests susceptibility is also a reasonable treatment option. So Pseudomonas, as I told you, it uses different mechanisms for resistance, and it uses this mechanism in combination for even by a single bacteria. So for severe infection, we can still stick to the novel beta-lactam agents, so when they are susceptible. So what are the preferred antibiotics for treatment of uncomplicated cystitis caused by difficulty to treat Pseudomonas aeruginosa? So the recommendation is ceftriaxone tazobactam, ceftazidime-avibactam, imipenem, cilastatin-rilobactam, cefeprodol, and single-dose aminoglycosides are preferred. Colistin, but not polymyxin B, should be used because polymyxin B doesn't reach the urinary tract. And oral furfomycin for difficult to treat Pseudomonas cystitis is associated with high likelihood of clinical failure. Oral furfomycin is for especially for E. coli, and it shouldn't be tried for difficult to treat Pseudomonas aeruginosa infection. So what are the preferred antibiotics for the treatment of pyelonephritis and complicated urinary tract infection caused by difficult to treat Pseudomonas aeruginosa? The options are similar. In patients in whom the potential for nephrosis is deemed acceptable, once daily aminoglycosides are an alternative. So this is only difference. The other options are similar. So what are the preferred antibiotics for the treatment of infections outside of the urinary tract caused by difficult to treat Pseudomonas aeruginosa? So if it's outside of the urinary tract, ceftriaxone tazobactam, ceftazidime-avibactam, imipenem, cilastatin-rilobactam as monotherapy are preferred options for the infection. And also ceftriaxone is recommended as an alternative option for difficult to treat Pseudomonas aeruginosa outside of the urinary tract. Ceftriaxone is being preserved for this metallo-beta-lactamase producing bacteria. So what's the role of combination antibiotic therapy for the treatment of infections caused by difficult to treat Pseudomonas aeruginosa? So combination is not that much preferred. Like if there is susceptibility to the other agents, the first line in vitro susceptibility antibiotic has to be used. Combinations, if no preferred agent is demonstrated against difficult to treat Pseudomonas aeruginosa, an aminoglycoside can be considered in combination with first line antibiotic. But if no aminoglycoside demonstrates in vitro activity, polymyxin B can be considered in combination with beta-lactam. Beta-lactam is inhibitor. So this is especially, it's not for double coverage of Pseudomonas. This is for difficult to treat Pseudomonas aeruginosa infection. So we can combine if there is no, if aminoglycoside susceptibility is not present. Even they, in the Westerns, they try even bacteriophages, viruses that can eat bacteria for difficult to treat Pseudomonas aeruginosa infection, especially in burn patients infected with Pseudomonas aeruginosa. It's very difficult to treat it, and there is success even other alternatives like bacteriophage treatment. Viruses that can eat bacteria can be tried in difficult to treat Pseudomonas aeruginosa infection. So it uses different mechanism and its management is very difficult. So I'm not talking about double coverage of Pseudomonas. I'm against that, and there is no clear data supporting double coverage of Pseudomonas. But for difficult to treat Pseudomonas aeruginosa infection, we can combine like polymyxin B with novel beta-lactam is inhibitor, like polymyxin B with ceftazidime-avibactam. Polymyxin B is preferred over colistin for urinary tract infection because since it's safe, it's safer than colistin. Polymyxin B is preferred. So this is the 2021 IDSA guideline. It's almost similar. Duration of therapy and de-escalation. So presence of resistant pathogen doesn't mandate prolonged antibiotic therapy if DTR P is used. So we have to stick with our 5 to 7 days of treatment. and we have to prolong if there is a clear reason for prolonging, like infective endocarditis, osteomyelitis, or undrained abscess. If there is no clear indication, antibiotic prolongation is not advocated. So where possible, step down to oral therapy depending on patient factors and demonstrated pathogen susceptibility. If the patient is stable and if there is susceptible, if there is an antibiotic which can be used for the pathogen, the step down therapy should be considered, but the patient has to be stable, and also there has to be some there has to be demonstrated sensitivity for the oral therapy. So step down to a single agent, also an alternative, step down to oral therapy if the patient is stable, and if there is an oral agent which is susceptible, the pathogen is susceptible, you can switch to oral therapy. And also the other alternative is dropping the one antibiotic, like stopping one susceptible antibiotic, like when you are using polymyxin B, for example. If you use polymyxin B and ceftazidimide, if the patient is stable, you can like omit the polymyxin B or the ceftazidimide for the treatment. So this is also one alternative, de-escalation and step down therapy. So carbapenem sparing strategies. Actually, there is no clear carbapenem sparing. There is no term called carbapenem sparing strategy after the Merino trial. The Merino trial is a very extensive RCT, which is done for 3 years in 26 sites in 9 countries, and it showed that piperacillin tazobactam is not, meropenem is superior to piperacillin tazobactam for ASBL pathogens. That means for E. coli and Klebsiella resistance to ceftriaxone. So ASBL is defined as resistance to cefotaxime or ceftriaxone. For the ASBL infection, meropenem is preferred over piperacillin tazobactam. So we cannot use piperacillin tazobactam in ASBL pathogens. So carbapenem cannot be spared by using such strategies. But we can still spare carbapenems. For example, low UTI treatment. Most of you might have seen such cases. Symptomatic lower urinary tract infection or asymptomatic lower tract infection, and you do culture and it showed E. coli or Klebsiella only sensitive to meropenem. So people tend to use meropenem, but it's wrong, and we have to use nitrofurantoin. And if it's E. coli, you can use single dose for phosphomycin or weekly phosphomycin for 3 doses. So there are single dose aminoglycoside is also an alternative. So we shouldn't use meropenem in urinary tract infections. And also we have to decrease broad spectrum antibiotic use. That means if you decrease our broad spectrum antibiotics use, ceftriaxone use, shell generation cephalosporin use, ASBL occurrence will decrease. And also, if there is no ASBL, we will not use carbapenem. So indirectly, we can spare carbapenem using this strategy. And also, infection prevention strategies are very important. Infection prevention strategies are very important, and unfortunately, they are neglected in almost all setups. So infection prevention strategies will decrease antibiotic use, and when you decrease our antibiotic use, we preserve or revitalize our precious antibiotics, carbapenems or meropenem. So stewardship should be practiced in all setups. Stewardship should be practiced in all healthcare facilities, in all hospitals. It's because of how we use antibiotics that we are seeing resistance. When I say, for example, we should have like ሴፕታዚዲማ ሪባክታም ሀገራችን ውስጥ ይግባ ፖሊሚክሲን ያስፈልጋል ኮሊስቲን ያስፈልጋል ስል እነዚህ አሁን ላለው ችግር መፍትሄ ይሆናሉ ብዬ አይደለም መፍትሄ የሚሆነው አጠቃቀማችንን ማስተካከል ነው ዋና መፍትሄ የሚሆነው ግን since there is 20% resistance 30% resistance and in some centers as high as 50% resistance we should we should push stakeholders and also the ministry to bring at least polymyxin and colistin and also the newer beta-lactam is combinations. They are not the solution, but we have to have them. They are not as precious as meropenem. We are losing meropenem. So they are not as precious as meropenem. They are not new medications, but they will help to treat carbapenem-resistant infections. So we have to have them, but they are not the solution. They are not the solution. Like ቀዳዳ ባሊ ውስጥ ወይም ቀዳዳ በርሜል ውስጥ ውሃ እንደመጨመር ማለት ነው ስቲዋርድሺፓችን ስትሮንግ ካልሆነ ኢንፌክሽን ፕሪቬንሽናችን ስትሮንግ ካልሆነ አንቲባዮቲክ ፕራክቲሳችን ስትሮንግ ካልሆነ አንቲባዮቲኮች ለዲዚዞች ትሪትመንት ናቸው ብለን ለሁሉም ዲዚዝ ትሪትመንት ናቸው የፎይታ ጊዜ መስጫችን ናቸው ብለን ማሰባችን እስካላቆምን ድረስ ይሄ ችግር አይፈታም Antibiotics are temporary measures. Like you have to control the source, you have to properly diagnose the patient. The patient will not improve if you put him on meropenem and leave him in the wards. You have to diagnose specifically the cause of the disease for the patient. We have to do source control. Antibiotics are temporary measures. If you give them for 1 week, 2 weeks, they will stop working. So if you have to drain an abscess, you have to drain. If you have to cut a limb, you have to cut a limb. If you have to remove a central line, you have to remove it. If you have to remove like a catheter, you have to remove it. So antibiotics are temporary measures and they stop working and they are not solutions for our patients. So to finalize, we have almost used an hour. To finalize our discussion, the only way out to emphasize is to emphasize on infection prevention and to limit irrational use of our beta-lactams. We have been using ceftriaxone here and there, and there is more than 80% resistance for ceftriaxone. And this ceftriaxone resistance will force us to use meropenem, and now we are seeing carbapenem-resistant in a lot of patients, 20%, 30%, 50% of gram-negative pathogens isolated. So we have to put in mind that antibiotics are temporary solution. We should focus on source control. We should focus on proper diagnosis of patients, proper diagnosis of patients. So we have to revitalize our carbapenems. Let us revitalize our carbapenems, meropenem. Thank you for listening.